All right. Next slide, please. Thank you. All right. The objectives for this evening are to build a relationship with a patient affected by migration and trauma. We'll look to co-create a treatment approach for pain that takes trauma into account. And lastly, access to community resources to learn more about the context important to newcomers to Canada. And so without further ado, I'd love to introduce Dr. Shay Akinola to us this evening. She's an internationally educated academic family physician, originally from Nigeria. She completed her family medicine residency training at the University of Calgary, and she's triple licensed in her home country, the United Kingdom, and Canada, with a master's in public health from the University of North Carolina and the United States. She also is a clinical assistant professor with the Department of Family Medicine, University of Calgary. And she has a special interest in vulnerable and undeserved populations with a split practice between Sunridge Family Medicine Teaching Clinic and the Mosaic Refugee Health Clinic here in Calgary. She's also an investigator with the Equity in Health Systems Lab, and that's based out of Ottawa. Additionally, she's an executive board member of the Black Physicians of Canada and holds the role of secretary. And she sits on several EDIA committees, including the Cummings School of Medicine Education Advisory Group. And she's a chair of Black Health and Wellness ICMA focused health track for the AFMC co-chair, the ICMA EDI and AR advisory group, and an EDIA mentor, adaptive mentorship network for teen primary care with the College of Family Physicians of Canada. She is a committed national advocate for the integration of internationally educated physicians in Canada, and she's very passionate about racially concordant mentorship for young people from marginalized and underrepresented populations. A public speaker, author, blogger, and recipient of the 2023 International Women's Day Outstanding Achievement Award by the Alberta Minister of Trade, Immigration, and Multiculturalism for her leadership and continued commitment towards her community here in Calgary, Alberta. So without further ado, I would love to welcome Dr. Shay and really looking forward to her presentation this evening. I'll pass the mic over.
Thank you so very much, Nicole, for that warm, a little bit effusive welcome. You were making a Black girl blush, but thank you. It's an honor to join you this evening. Thank you for the invite. I see a lot of colleagues and in various disciplines, and I appreciate you joining us on this beautiful evening where you can be elsewhere. So without further ado, I'm just going to, jump into the meat of this evening's presentation. Just give me a minute here. Nicole has done a very fantastic land acknowledgement, but I also just want to say, in addition to what she said already, that as an immigrant to this land, I consider myself very privileged, and I remain committed to listening to my Indigenous brothers and sisters and thinking about the respective ways in which in my everyday I can contribute my quarter to reconciliation in this beautiful country, and I encourage all of us to do the same, especially doing it when no one is watching. This evening, we're here to talk about pain and trauma related to migration, another new normal in Canada. Why do we say new normal? Because I'm not sure why the pain groups called it a new normal. They gave me this topic. They wanted me to speak to it. But in thinking about it and reflecting from my lens, my lens as an immigrant, as someone who migrated here 10 years ago this year. Secondly, as a provider to migrants, including refugees, I thought about that new normal as the statistics are getting higher and higher in terms of the newcomers coming into this country. I'll share that with you later. Um, I do not have anything to declare other than the fact that I get a small honorarium working with the Bruyere Research Institute located in Ottawa. The learning objectives for today, we've gone through it earlier, but I'll just reiterate it again. One, at the end of this evening, I'm hoping that you're comfortable with taking on refugee patients or patients who are new immigrants to Canada, even if they do not look like you, speak like you, but they're people who've been affected by migration and trauma. I'm hoping that you're able, maybe not, even if not 100% confident, but to an extent more confident than the start of this presentation at your ability to build and foster a relationship. I'm hoping we can co-create a treatment approach for pain that takes trauma into account. And I will be sharing some resources that are both here in Alberta and across the country, should in case we have people joining us from outside Alberta, or if you do decide to, pick up your bags and migrate to another province. So just to get a feel of our thoughts about this evening and how comfortable we are, if you can indulge me, I would just like to have a few ideas of what people think migration is. When you hear the word migration, what comes to mind? Buddy, feel free to unmute yourself and just say it. Should I go on,
I
Nicole?
think being as like the movement of people or relocation is what comes to mind right away.
Absolutely, you're totally right. So when we talk about migration, it is that voluntary picking up of your bags from where that is familiar to you and going somewhere else for several reasons. People do it for economic reasons, persecutory reasons. There's so many reasons why people migrate from place to place, and migration can be across borders or even within a country. So that is just the simple definition of migration, and this picture here is just showing us there's a plane right behind. Some people are coming off that plane, and if you look at that boy, he has a steady behind him, I guess for comfort, and they're not quite sure what the next steps are, but they're getting off that plane. And, just to have a feel of who are the people who come here to Canada. And this is from 2022. And at that time, if you just look at the snapshot of, I'll call it the newcomers, we've got the biggest chunk being temporary migrants. We've got the economic immigrants. So I consider myself an economic immigrant. Then we've got the family class immigrants. Family class immigrants are people who already have family members here in Canada, and then they fulfill certain criteria made by immigration, and they're able to invite their family members over here on the premise that they're able to take care of them. Now, look at that chunk of refugees, and then we have the student visas. I focus on the student visas because those people will become economic immigrants. Most of them would apply for a permanent residency on completion of their studies. This right now is the latest immigration data from the United Nations, and the International Organization for Migration had this poll. And for the data, we look at who was the sex, of these people who are coming in as international globe migrants. This is globally, this is not just in Canada. And just to have a share idea of how big this number is. Imagine that 3.6% of the population of the entire world are migrants somewhere. So they're shifting location from place to place, and we have that number, female. We have more males, but that is gradually closing in. This is an old data from 2019 talking about labor migrants, but I just wanted us to just have, this snapshot just to have an idea of the population of people that we're talking about. So Nicole just told us who a migrant is. Now, who is a refugee? Anybody? These are words we use every day, sometimes interchangeably, sometimes we use it the same way, but I just wanted to make a distinction between who a migrant was and who a refugee is. Do I get an helper? Okay, so a migrant is someone who makes that decision to leave from location A to B. But a refugee is someone who is forcefully displaced. So they did not have a choice, but they are forced to flee their own country, and they become without protection of that country that has sworn to protect them, and this could be for a myriad of reasons. But the difference between a migrant and a refugee is, one, this is involuntary, they have no say in it, and they cannot go back. As a migrant, myself, if Canada wasn't working out, I could pack up my bags, pick up my passport, and say, oh, I'm going back to my home country. But for a refugee, they have lost that protection. They cannot go back home. And that is a very core distinction between who a migrant is and who a refugee is. Now, this is a global picture, of the refugees we had as at 2021 to middle of 2022. This, it would have been too much to begin to put it country by country, but I just wanted us to see the millions, hundreds of millions of people that are forced to become refugees every year. And the stats for 2023 is even different. And this was taken from the UNHCR information. So now back to our topic for this evening. We were talking about trauma related to migration, and I wanted to make us understand that when we use that word migration, we are referring to two distinct populations of people. We are referring to migrants as well as refugees. And a lot of us have a tendency to just lump up refugees, as, oh, the refugees, and not making that distinction that they're a very heterogeneous group, a very different group, different cultures. And it is important, when you have these patients before you, not to generalize them as one group of people. It's important to see each and every one of them as an individual for who that person is. And when we talk about refugees coming to Canada, how does the government make that informed decision for the people they are taking? Another distinction between an immigrant and a refugee. So for refugees, the government prioritizes the most vulnerable. And I have a list of them here. They prioritize women and girls at risk. So I'm talking about the government of Canada. They prioritize survivors of violence and torture. They prioritize family reunification, so people who've been separated for years from their families, they want to bring them together. They prioritize people with medical needs and children who are at risk, as opposed to with immigration. If you're not healthy, that is a definite exclusion criteria. They only want healthy migrants who can contribute to the economy of the country. Annually, we have almost 500,000 immigrants as well as refugees in total who come into this country. And just in 2023, we had more than 8 million people who were permanent residents of Canada. And if you look at those stats, you see that gradual increase, from year to year. From 2019, there was an increase in that number by 7.3% to 19.5%, 0.15 in 2020. And, so there's been that gradual exponential increase. And that was why I thought that the pain rounds, you chose to say the new normal, because truly it is a new normal here in Canada, and it's not one that's going to go away anytime soon. We made this distinction earlier, economic migrants who are unhealthy, they are excluded from coming to Canada. However, unhealthy refugees are the ones who are selected, and remember, they have greater health needs. Now, what is trauma? What do we understand by trauma? So this definition of trauma was from the International Organization for Migration, and it defines trauma as resulting from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Did somebody say something? All right. So I'll just give you a moment to digest that. It was quite a mouthful, and then I will move on. There are various types of trauma, but in relation to displacement or migration, that experience for most of the people who have experienced war and become refugees, that experience really just it breaks down that illusion of safety, and they become increasingly vulnerable. And it's because of the life experience they've just been through, and they have different examples of these traumatic experiences. Just the fact that you have to forcibly flee. I had the luxury of planning, of moving. It was well planned and I was prepared, but this is just, that abrupt is abrupt. It can be due to cultural conflict. It can be due to fear of political upheaval, in fear of imprisonment. It can be as a result of sexual violence experienced during this journey, or it could even be a result of environmental disaster. And in such situations, you cannot even take tiny personal items that may bring you comfort while you're away. And there's a lot of disruption of family. And then the things we call the basic amenities of life are suddenly non-existent, no shelter, no food, no resources. And these are just a few examples of the kind of traumatic experiences people going through this journey could experience. And what impact does this have on mental health? So broadly speaking, that experience that's most of the patients that we deal with do have post-traumatic stress disorders. It may not be named, they may not recognize it. It may disguise under somatic conditions, but most of the patients that come to us from that context have PTSD. Most of them suffer from depression. Most of them suffer from anxiety. And of course, they are grieving the loss of their normal. They're grieving the loss of life as they previously knew life to be. They could also be grieving the loss of loved ones, and in addition to this layer of the mental health issues they're dealing with, then you now have that compounded factor of language barrier, cultural barrier, inability to access health services, and even that context of mental health services is very foreign to many people, so inability to access all of this, and overarching everything is the financial inability. With money, you can access a lot of things, and a lot of these people do not have the luxury of those resources. When we have all of this trauma, it can either lead to some other conditions, or it can exacerbate some underlying medical conditions or chronic conditions that they already had. So now we get to substance use and abuse, in order to deaden the pain that they feel. Or you can have manifested physical health conditions, and, a lot of times, all of us here, we've used the word adverse childhood experiences. We had that study, that big CDC Kaiser study, and all of this, have long-term impacts on on physical health. And, studies have shown that there's actually, with the depression that comes with migration trauma, there's actually up to 12 times the increased risk of suicidality in this group of patients. And many of them do not actually fulfill their expected life expectancy. And there's an overall about a 20-year decrease in their overall life expectancy. So all of these are impacts of this kind of trauma that we're talking about. So I've told you about who a migrant is. I've told you about who a refugee is. I've told you a bit of some of the kind of trauma that they experience, but then there are parts to this trauma. At different phases of that journey, the trauma is different. So let's start from pre-migration. For a migrant who is coming in, but pre-migration stage, or you could call it the gestation stage, is in utero, is brooding, is growing, this preconceived idea of, oh, I think it would be nice to move to this country. Or if it's a situation where it's a war-torn environment, then they're beginning to put all of those papers together as to where can we seek asylum. Then people begin to reach out to family members who are in other countries that are deemed safe, asking how can we come. And in this phase, the educational background is very important. The occupation is important. Financial literacy is important and baseline health. All of these are important because that may be a huge predetermining factor in the kind of life these people eventually settle down into when they get to their destination. If it's in cases of immigration, we actually have migration health assessments that happens, and that is where people get weeded out, either included or excluded. So for migrants, if they're not optimized in terms of their health, that's where they get removed from the process. And for refugees, that is where it is determined who is most vulnerable, with increased health needs and can go forward. Also within this pre-migration phase, you have a lot of when I was listing the kinds of situations that can cause people to flee, imagine if, somebody fled from a war zone and right now is in a settlement camp, with so many people. You see some of those pictures on TV, and those are real life experiences. I have so many patients who that was their day to day, they're within that barbed wire, under open tents, open to the weather elements, and all sorts of physical, mental, psychological, sexual abuse can go on in there, even by the officials supposed to be looking after these people, and then we move on to the migration process. I had a picture earlier, showing some people drifting on the open seas, and that was a kind of migration process. Every year we hear about people dying on the Mediterranean in trying to cross to Europe, maybe from Africa and all of that, so that migration process itself can be quite turbulent. And then you get to what we call the arrival or reception stage, and in this stage, that's where all of the paperwork in terms of integration in that new place where you now find yourself, that's where that happens. And it also comes with its own kind of trauma. And that's where things like access, begin to come up. That's where the language, if you do not speak the language of that place, that's where it comes up. That's where the cultural shock begins to show up, and with settlements and immigration, you have some of those things if there's no support. And of course, what does that mean? Even more trauma and the way it presents. Now, in Canada, I want to show you a broad picture of where we have specialized services for newcomers to Canada. Because we're in Alberta right now, I'm going to focus on Alberta. I am in Calgary, so I naturally know more about what's going on in Calgary, but we do have a subspecialized clinic in Edmonton run by Dr. Marlene Warden-Brown, who is also a family physician. And then here in Calgary, we have the Mosaic Primary Care, Mosaic Refugee Clinic, and I'll tell you more about that later. This brings me to the second part of our objective today. How do you build relationships with patients who have been impacted, by trauma? Any ideas? Because I know some of us here have been working with this population of people before now, and you are here just to know more to what you already do. Well, in terms of building relationships with people who have been impacted with trauma, the very first thing is understanding their trauma. You want to understand the background of this person's trauma. You want to be familiar with the resources that you have in your capacity in supporting this group of people, and these are just some examples of some of the papers that have been written, on common mental health problems in immigrants, refugees, just general approaches. This was published in the CMAJ. It's old. It was in 2011. However, it is still very relevant because these are problems that remain the same. And just highlighting here, I talked earlier about differences in the language, in the culture, and all of this can pose a problem with resettlement when we talk about immigration. So this right here is just a snapshot of some of the problems, mental health problems that we see in people who have migrated or who are refugees from one place to the other. Things that exacerbate their current mental health issues could be, there's a group I didn't touch on, and those are people who are here illegally, who are here because they want to seek asylum and ask to remain here. I didn't touch on that separately because at the end of the day, it still boils down to somebody has left what is familiar and has come to what is unfamiliar with the intention of either being here temporarily or being here permanently, and some of those things that they experience, I had mentioned earlier could be substance use dependency, self-harm, psychotic symptoms, physical disease. We talked about 20 times the risk of suicidality, generalized anxiety, depression, dissociation from oneself. We see that happen very much, just to mask that trauma and remove themselves from that trauma in real time, hyper arousal, avoidance, your patients having sleeping problems, either flashbacks, nightmares, psychosomatic problems. All of these are real problems, and then we're going to just transition into talking about, what sort of approach can we apply in trauma-informed care, for these patients? How do we build that relationship when we have patients like this? But before I go on, I've been talking for a while, and I really am curious to see if we have any questions so far, and I'm happy to just pause here and um, respond to those questions, if any.
You are doing a very good job, Dr. Akiniola. So far, so good. So there are no questions. Everything is crystal clear. So, well, if somebody has a question, I would like to encourage you to unmute yourself and maybe ask directly.
Hi, just Nicole Johnson. Just a comment or a question to you, Shay. You mentioned knowing the trauma. I think it's important to talk about the fact that it's not always required to know the exact experiences that they had, but more to understand, uh, categories of experiences. Is that not right?
Absolutely. And we will flesh that more in here with the clinical pearls, but you are absolutely correct. Because, you know, relieving that trauma can be re-traumatizing in itself, right? So you cannot just do that unannounced. You need to seek permission, and so I would say more on that, but you're absolutely right. Thanks for the comment. So Jen, is it okay to go on?
I would say so. Let's do it.
Okay, I don't know how that makes me feel. When there are no questions, it means you're either doing a very poor job or everybody just wants to leave and get the hell out of here.
Maybe it
But
is a different dynamic when we do it online. It is different than having a live audience and having the different connection with them.
yeah,
So yeah, that's the technology.
all right, thank you so much. So I just want to share, I try to, make it as concise as I could, and you having a good grasp, not just giving you lots and lots to work on. So the very first thing here is practicing a strength-based approach to care. So what exactly do I mean by a strength-based approach to care? So picture this scenario. You have this patient who walks into your office, they're a new patient. So pretty much the same way you do a meet and greet with all of your regular patients. It's just that in this case, you probably have a language line. Maybe the person doesn't speak English, and then they go through all of their experience. I usually start by saying, oh, where are you from? And they usually will tell me maybe the last country from where they flew into Canada. And then I say, where were you born? And then, oh, how long did you spend? Were you in a camp, or, were you contributing to the economy of where you were staying? Were you allowed to? So that opens a conversation. And within that conversation, I'm listening out for the things that were positive experiences. So for example, if they said, oh, I was living in this place with my parents, my siblings, we were all together in this one room, right there, what do I see? I see strength in family. I see a very, very deeply rooted family with core family values. And I jump on that. Or maybe this person mentions a particular experience that was quite comforting to them, or a positive experience, whatever it could be. Or maybe while I was there, I had this dog, and going on and on about all of the things you did with this pet, without even realizing that this was a therapy support animal, and then I capitalize on that again. So I echo the strengths I hear in the story. So not just on that negative experience of all of the bad things that happen to them, but while listening, jumping on what I hear is a strength. And if I don't hear, I clarify, I could redirect and say, oh, in all of this, were there any particular situations that you were really happy about? Oh, yes, when I had the birth of my baby in the camp, that was that you and that right there is something else to jump on, because it opens up more conversation without the anxiety or relieving, negative experiences. So that's one approach. The second approach here is, creating that immigrant-friendly healthcare environment. What exactly do we mean by that? In your clinic, what do you have on the walls? Do you have any poster, showing welcome in different languages? I'm not sure if I showed earlier, the different countries that are most populous within Canada, but even if it's just the top 5 and you have welcome in those languages, and if I come in and I don't speak any of those languages, but I just see a picture of 2 people smiling and maybe embracing themselves or shaking themselves, or it could even be one that depicts, the religious differences. It could be a woman in a hijab, who is saying hello to a Caucasian looking person and they're smiling at each other. Or it could even be, same-sex couple, not the usual same-sex couple that we see here, but maybe even 2 different race mixed relationship and same-sex, all of those are different kind of pictures that are evoking a welcoming environment. Taking the time to train our staff, you do need a particular level of patience to deal with people who are not the same as you, who have a completely different concept and background regarding healthcare, So even just training your staff on that added level of patience, on using the language line where you have the resource to do that. And if they come with somebody, there may be a policy of, oh, I just want to talk to my patient alone, but encouraging them to come with whoever, they find comforting, that trusted person who is with them, welcome them in that first visit. And then subsequently you can reassure and say, oh, we do have a tool here that speaks your language and will tell me exactly what you're saying. And if it's not quite coming across well, your support person can interject. So all of this is really creating that immigrant-friendly healthcare environment. Now, look around, look at your staff. Do they all look the same way, or do they truly look like Canada, truly look different? Walking into that environment where you can mirror or see somebody who looks like you, that also, quite comforting for this person who is new to that practice. And then within the healthcare environment itself, how do you promote that trust and relationships? Some people have a distrust based on previous experiences. Somebody coming in, you don't know that experience, but just being a good listener, and understanding that relationship building does take time and they will come again and again. So being ready to invest that time is a way of promoting trust within both parties, and actually even verbalizing it, letting them know that, what, this is a safe place. I cannot imagine your previous experience getting here. However, I want to reassure you that when you're in here, it is safe, except when I'm worried about you harming yourself or somebody else. Really just fermenting that, and over time they will come to understand that it is not just words. We're also careful to know that it's so easy to build a dependency relationship, so having different people, different providers within the practice, having that holistic, comprehensive care is very important for this population of people. And that comes to the PCN. In our PCNs, we have all of the different allied health, and we can utilize all of these different groups of healthcare providers when we're dealing with our patients who are migrants to Canada. The next thing I'm going to say is we talked about adverse childhood events earlier, and, as a provider, remembering and recognizing that, for the younger patients, there is an impact on that developing brain, and there are various ways in which this can manifest. So really, when you're screening these patients, really you cannot do everything at a first visit, is layered visit. And, we have that luxury in the refugee clinic of spending up to 2 hours at that initial visit. We call it an intake visit, but we don't have that luxury anymore. The healthcare system is changing. We now have different pillars of the EHS that's coming up. We have that transition process taking place. We have over 600,000 Albertans who do not have a family doctor. So now we're encouraging you that it's not just something the refugee clinic alone can take care of. Colleagues, all of us in the community, this is absolutely something that we can take on. And as time goes on with that new patient, having spent that invested time early on, and then slowly over time, you begin to spend less and less and less time, such that by the end of, let's say, 2 years, you're spending the same amount of time with this group of patients as with your regular patients, but then you put in that work early on. And trauma-related disorders, treating it appropriately, the same way you will treat any of your mental health disorders, the same approach in terms of, psychotherapy as well as medication therapy, and, taking away what stressors can we deal with, what resources do we have to take care of some of those stressors, is the exact same way. It's not different for this group of patients. What do we mean by utilizing a 2-generational approach to care? So earlier I mentioned the example of, a multi-generational family, maybe sharing a room together, So we have that family unit. So when you have parents, grandparents, and children coming to the clinic, instead of separating those visits, you can have a grandparent and a parent. They can come together. You can encourage them to come together, for the visit, because the way the grandparent has dealt with the trauma can be different from the way the parent has dealt with the trauma, and them interacting and talking about it with you there, not just maybe as a moderator, as a spectator, or just as a listener and offering the resources, it really does go a long way in supporting them. So they feel comforted and supported, and they're offering that support to one another because they already have that baseline trust between them, which is going to take time to build with you as the resource provider. So if you have that advantage, really utilize it, or instead of when you've established care with maybe a young adult, and if that young adult has parents, with their permission, you can ask that, would they like to access resources together? Let's say you're sending them on to a specialist, would you like us to book your appointment together? And so that way, when they get to that strange new environment, they have that familiar presence with them, and they feel more comforted and open to talking to the new people who they may find distrustful to start with if they were on their own. again, knowing what resources are local to you, and verifying these resources. Sometimes we have some resources and we're like, oh, okay, this is available, but really verifying it, informed verification, you can ask colleagues, have you used this? We are also very open to getting questions from our colleagues. Just recently, Dr. Nixon reached out to me asking about support, for some patients of hers who refugees who were dealing with addiction. And I didn't have the answer right away, but I said, you know what, I'll check with CCIS if we still have that resource, and I'll get back to you. So there's really nothing wrong with asking, even when you're not sure. And I have some of those resources that I'll share with you at the end of the presentation this evening. Recognizing that trauma may not end after migration. Absolutely. Every day, there are triggers, it takes many years to truly settle down. And that trauma can be relieved over and over and over again. So ability to provide ongoing support, long after the 2 years of support from the government, IFH is over, but being able to do that. And lastly, I know that our job as family physicians, part of our role, it's advocacy. But when you're advocating for somebody who is vulnerable, who is underprivileged, it's a whole new level to advocacy. And it doesn't matter, you do not have to be in government, you do not have to be in management to advocate. Just even little things, little things go a long way. A few months ago, someone joined a new practice, and part of her panel, a friend of mine rather, part of the panel she was hoping to build is she wants to be able to cater for immigrant and refugee population, and they didn't have a language line, and she took it upon herself. She was able to get the management of that clinic to get a language line, so that is a very small piece of advocacy, but it's still advocacy. And then when we go to the national level and we talk about advocates within Calgary, like Annalie Coakley, who lose many sleep advocating for this group of people. So again, as providers, when you meet your patient and you see their needs, advocating at whatever level you can really does go a long way, and it does show your patient of your commitment and further cements that trust, that your patient has, not just in you, but also, in the healthcare system. A very common example of advocacy that I do on a day-to-day is I refer a refugee patient somewhere, just like the entire healthcare system, everything is taking much longer than it used to, but when I recognize that, okay, this is a surgery that cannot wait, is surprising this person did not have complications before now, just picking up that phone and speaking to Specialist Link and saying, hey, you would do that for your regular patient, but then really adding that extra layer of, this person and putting that personal touch to it, sometimes you never know when it does, go a long way on the other side. Now, I talked about the refugee clinic. I'd mentioned earlier that I have a split practice there, but why do we have that specialized refugee clinic? I said we have one in Calgary, we have one in Edmonton. We have that just because a lot of these people coming in, imagine an adult in their 40s, in their 50s, and they've never been seen by a physician. Yeah, we have so many. Or when we had the Syrian and Afghanistan refugees last year, 2 years ago, we had a lot of women who we were seeing in their 8th month of pregnancy and had never been seen by a provider. never had prenatals, so you have a high burden of neglected physical and mental health conditions. You have a high burden of infectious diseases. As a matter of fact, we've had to create special programs. For example, we'll have a special program with a TB clinic, and we're able to order tests that usually it will just be the pulmonologist that will order it, or having our own liver programs for people with hepatitis, just because you have complex neglected chronic diseases or undiagnosed congenital diseases, or people who have very, very severe trauma. I remember the Yazidi group of people, and you would see neurogenic seizures. These are seizures that you're seeing the patient sees in front of you. There were no epileptiform changes on their EEG. All sort of tests were carried out, neurology in foothills. And at the end of the day, it was ruled as neurogenic seizures as a result of complex traumas, But when you look at all of these things that I have talked about, it is nice if we have a specialized refugee clinic. But since we don't, and we have more and more, we saw the data, we have more and more people coming in every year. So it means that in our own spaces, we can provide this care, and a big chunk of it, that is the rate limiting step, is the remuneration. How do you justify spending 4 hours with a patient? You cannot spend 4 hours, but maybe you can spend 1 hour and bill for it. I think one of the things I really want to promote this evening is you embracing the idea that, okay, I'm open to having this group of patients in my practice, because we have several practices that just say, hey, no, we don't do refugees. We're sorry, but really just having that openness to say, okay, not a big percentage, but maybe I can stretch and I can take this many, and the rest is all about building that structure that you want in your practice. And I encourage you that these are the same kind of patients that you've been seeing. It's just that they're more complex based on their trauma from migration or from, if it was wars or whatever trauma that has brought them to this resettlement. That is why they're here. And I'd shared some nuggets that can help, with addressing that. Something that I think is important to mention is the very different expectations and perceptions of healthcare. It's so different. So for example, I come from fee for service. I come from a place where I don't have to book an appointment to go see my doctor. I can just walk in there and I'll pay for my service. So it's very, very alien to some patients when they now understand the concept of, oh no, you have to book an appointment. So again, back to the basics, taking time to do that education, taking time to train your staff in the expectations, and gradually debunking what they previously knew. And post-assessment, I shared this with you earlier. I'm just going to pass over this. And now I'm talking about the Mosaic Refugee Clinic. This is a resource that we have here with us in Calgary, located in the Marlborough Mall. And who are we, and what do we do really? Right now, these are the different group of specialists that we have working with us. We have community partners. We have 17 rotating family physicians. This is excluding the learners that rotate through our walls. So we have learners doing +1. We have early learners. We do not have medical students coming anymore, just due to the complexity, of our patients. And we have all of this allied health team working with us. So it's really quite a big group, a big happy group. Very mentally stressed, but that is a resource that you have here in Calgary available to you. The next one I want to talk about is the Refugee Health YYC Hub. So this is actually, if you type this into your phone, there's an app that comes up, and we've pulled together different resources with regards to refugee health that you can access. So you can punch this in and save it. It's an app that is very, very valuable, and a lot of research relating to refugee health within Canada and within the Oberyn public health is all that data is in here, and is an app that has been worked on by some dedicated colleagues within the refugee clinic. Is it okay to move on? All right, I'll take that as a yes. So here, this is another tool. So this is the CCIRH. It is the Canadian Collaboration for Immigrants and Refugee Health. Again, a lot of resources in there, a lot of information, lots of guidelines, and it is located in Ontario, but the online resources are invaluable. So that's also somewhere that you can access. Caring for kids new to Canada. So this is under the Canadian Pediatric Society. So it's within their app, and you can click on the Caring for Kids who are new to Canada for your pediatric patients. And again, they also have very valuable resources in there. If you want to access some online courses, I'd mentioned the CCIRH earlier. So this is one of the courses that they have, and it is called Refugee and Elderly Global Health e-learning. So it's got different modules, and the modules are interactive, and they're modules that you can actually do and take a quiz in the end, and you do get a certificate of completion. Now, for the Immigrant and Refugee Mental Health Project, this project came out of the University of Toronto, and they have is a toolkit of mental health resources for providers, not just for physicians, for any mental health providers. And I encourage you to visit that page. And they revise their resources from time to time. I'm actually a peer reviewer for them. The last peer review was done in 2022. So it's revised every couple of years. So very up-to-date resources. Yeah, these are some papers in terms of practice guidelines for mental health programs for refugees. I just put a snapshot of this paper, and this paper came out of the CCIRH and the Center for Addiction and Mental Health. So again, visiting those websites are, they're valuable resources embedded there. Now, this is the McGill Summer Institute in Global Health. I actually attended this course, this course was just done this summer, June 12 to 14. Even though this is something I do every day, but I found it enriching. We had the WHO director at the course as well. And this was providing healthcare to refugee, immigrant, and migrant populations. So those distinct populations really broken down. And this was the first time they were offering this course. It was over 3 days. It was online as well as in person, and they're going to be offering something similar every summer. It will be different topics, obviously, but this is something you can look into. For my online registration, I think it cost about $450. I really cannot remember. And no, I do not get any honorarium. I'm not promoting this I'm just promoting it because I enjoyed it, and it is a resource that was available, and I thought to share it here as well. Now, this Refugee Health Coalition has a whole lot of resources regarding refugee and migrant health. So I encourage you to, take a picture of this. It's a big hub, and then you see different organizations who are actively involved in providing services for this group of people. So I hope you find it useful as I found it useful over time. So right here is the website that you can visit, and it's got the resources under the Refugee Health Coalition. I think we've come to the end of this evening's presentation. Thank you so much for your rapt attention. And I say very big thank you to the Pin Rounds for having me. It was an honor to speak to you all this evening. Thank you very much.
Thank
I'm
you very
open to
much.
questions.
Yeah,
Hello.
again, so if there are any questions, please unmute yourself and just go ahead and ask.
It's not any question. Can I make a comment?
Sure.
Hello. This is Mary. Akinola, you have done such an excellent job that has removed a lot of, questions. And like some of us who are really working in hospitals are working with the doctors, in Slave Lake, Summer Clinic, the family care clinic,
Thank
where
you
we
for
call
joining.
it a one, we call it a one bus stop where you meet literally everything. Your, presentation this evening is really timely. And with that, lots of where could I get some of the resources that you have given us that are so invaluable? Thank you. I cannot say much about it, but really you brought a lot of good things that, like me, I don't know about the others, but you have enriched me so much. And that I'm very happy, for whatever that you brought. Thank you and congratulations.
You're welcome, Mary. I hope you find the resources useful.
Hi, I just want to ask my name is Agnes. I just want to ask, what is the wait time, so to speak, to access the specialty refugee clinic?
So for the refugee clinic, the inclusion criteria is they have to be refugees, government-sponsored refugees to Canada. So there is no wait time on arrival at documentation. As soon as CCIS, has done all of their documentation, they come to us first, before accessing any doctor in the community. So they come directly to us. We do what we call an intake screening. And right after, so that intake screening is really for all of the infectious diseases, determine the chronic diseases, link them up with specialists that they need to see. Before AHS breaking down into the new different pillars, we used to have that resource for 2 years because the federal government will provide funding supported by the provincial healthcare. And we would have these people for 2 years with the goal of transitioning them to community physicians over the 2 years. But right now, we do not have that capacity, unfortunately, because of funding restrictions. So what we're currently doing, what we've been doing since the beginning of this year actually is, as soon as we get these patients, we do that intake screening, and then they come for a second visit where we review all of those resources, and then we transition them to community. Before we could help, but now we just give them the list of, doctors accepting patients that we are affiliated with Mosaic PCN, or depending on what part of the city where they live in, the PCN connected to that area, we give them that list, and we hope that they have someone who can translate for them. And our staff actually go the extra mile of, helping them get connected, but there is no wait time to access in our clinic. They just have to be the right patient. So our clinic does not deal with migrant patients because those are economic migrants. We deal with refugees. So the people who've been identified as the most vulnerable, who do not have a country, who Canada has said, hey, come on, we're going to give you shelter, So those are our patient population, and they're the only ones we can attend to. I hope that helps, Agnes.
Yes, it does. Thank you.
Well, there is one technical question in the questions and answers. If this recorded session will be available to view in the future. So can I ask our technical tech guys like to post a link there, perhaps somewhere where people can access the recording in the chat or the answers? Well, so you talked about mental health issues in refugees. I'm curious about access to the PHCs, behavioral health consultants in your clinic. How easily can they be seen? And should advocacy include having more BHCs access than other clinics?
So unfortunately, we also are suffering from the same problem of access, like the rest of the province, I'm sure. But what do we have? We have the Mosaic PCN. We have the Mosaic PCN. We have 3 behavioral health therapists within the clinic, which is definitely not enough. So that means that each and every one of the providers there has become a therapist as well. You know, a lot of us have taken courses. We have a lady who's actually developed a toolkit, is Dr. Christine. The toolkit is called the mental health trauma informed toolkit. You can punch that in, it should come up, you know. So that's a resource that one of us has created that is used all over North America. But we have mental health nurses too. Definitely nowhere near enough as to what we need for our patients. So we just make do with what we have, unfortunately. And Access Mental Health is something we utilize a lot, you know. We utilize Access Mental Health a lot, but there's a language barrier, you know, and Chronic Pain Clinic also also sees, you know, some of our patients, and again it becomes that problem of transitioning them out, right? But if they have a primary care provider, the chronic pain clinic does a very good job of connecting with the provider directly. I have had that happen many times with some of the providers here this evening. So I hope that's a little bit helpful. I must tell you, it's very emotionally draining. You know, a lot of times you feel helpless, you know, but then I remind myself of the positives. You know, look at the things you've done well. This person has never seen a doctor in their 50 years of existence. And in this 1, 2, 3 visit, I want to fix all the problems. I can't, you know, just accepting that I cannot, you know, but then being able to chip a little at a time. I think that's good enough.
Okay, well, it seems like this is it. I don't see any other questions. So thank you very much, Dr. Akinola, for your passionate and informative presentations about the issues new immigrants and refugees are dealing with and how we can help them to feel a little bit better, welcome, included from the very beginning. So your expertise and insight on this topic definitely captured the audience because like there was pretty busy chat going on, like people kind of telling each other stuff, their own personal experiences. So it was good. And again, we didn't have any questions because I said before, like everything was crystal clear. It was good. So it was very informative. So once again, thank you very much for your time, for your effort and expertise. And hopefully we will see you once again somewhere there in the future.
Thank you so much for having me.